Good morning, ladies and gentlemen. Welcome to the Young Physicians Forum and the college lecture by the Ceylon College of Physicians. We have 2 more minutes to go, but we'll start so that the speakers can come to the podium and start. The first lecture is by Dr. Seniru Sohen Welgama, MBBS Colombo, MD Medicine. Dr. Seniru Sohen Welgama is a senior registrar in internal medicine at Professorial Medical Unit, National Hospital of Sri Lanka. Dr. Welgama obtained his MBBS with first-class honors and multiple distinctions in the year 2017 from the Faculty of Medicine, Colombo. He completed his MD Medicine from the Postgraduate Institute of Medicine, University of Colombo in 2023. His areas of interest include infectious diseases and non-communicable diseases. The topic that he has chosen for today is resistant hypertension, a rising threat to tackle. The speaker will speak for 25 minutes and another 5 minutes will be allocated for questions and answers. Over to you, Dr. Welgama.
Good afternoon, ladies and gentlemen. Thank you very much, sir, for the kind introduction. And first of all, let me thank the CCP for granting me this wonderful opportunity to speak at this prestigious forum. The topic that I have chosen today is resistant hypertension, a rising threat to tackle. So, what is resistant hypertension? A blood pressure of a hypertensive patient that remains elevated above the goal despite being on 3 antihypertensive agents of different classes. These 3 classes are preferably a long-acting calcium channel blocker, a RAS blocker, either an ACE inhibitor or an ARB, and a diuretic. All these drugs should be administered at the maximum possible tolerated dose or at the maximum possible dose for that particular patient. This definition also includes patients whose blood pressure is achieves the target values while being on 4 or more antihypertensive medications. So what is this goal value that we are referring to? Is it 140/90 or is it 130/80? Most guidelines, the European guidelines as well as the International Society of Hypertension guidelines recommend a cutoff of 140/90, whereas most studies on resistant hypertension are also based on this 140/90 cutoff. However, American guidelines suggest a lower cutoff of 130/80 millimeters of mercury. As well as it's obvious that the incidence and the prevalence of resistant hypertension will increase substantially when the lower cutoff value is used, thus increasing the treatment burden. The latest guidelines that we have available on hypertension, which are the 2023 European Society of Hypertension guidelines, also recommend this 140/90 cutoff. So as you can see from this graph, this is the two of the largest trials on hypertension, the SPRINT trial and the ECHO trial. In the post hoc analysis of participants without baseline refractory or resistant hypertension, they have been intensified to the less than 120 millimeters of mercury treatment target, as well as standard less than 140 millimeters of mercury treatment target. Of these patients who have not been having refractory hypertension at the baseline levels, the cumulative incidence of resistant hypertension when these patients have followed up over the years have risen up to 30.3 per 100 patient years, where when using the lower cutoff of 130/80, whereas the cumulative incidence is only 9.7 when using the cutoff of 140/90. Similarly, the point prevalence at 1 year is the CORD BP trial of resistant hypertension in follow-up is 36%, whereas it increases to 48% at 4 years, and in the SPRINT trial it is 22% at 1 year, and it increases to 26% at 4 years. This is when using the target cutoff of 130/80. But when you are using the lower cutoff of 140/90 to define resistant hypertension, the point prevalence of resistant hypertension in this in these patient cohorts falls to 14% and 7.5%. So because of all this, the European Society of Hypertension guidelines recommend the cutoff of 140/90 for diagnosing resistant hypertension. When we encounter a patient with resistant hypertension, the next question that we have to ask ourselves is, are we using the maximum dose of antihypertensives that is acceptable to the patient? So we have to go back to our pharmacology books and see what the maximum possible tolerable dose of hypertension, antihypertensive drugs that the patient, we can start the patient on. So what is the prevalence of resistant hypertension? The prevalence differs, has been very difficult to analyze because of the non-uniformity of factors such as the clinical setting, the drugs used, and the blood pressure cutoff that have been given by various definitions. However, values ranging from up to 5%, even up to 50% have been reported. So this bar graph shows the prevalence of resistant hypertension as reported from selected population, clinic and intervention-based studies. These are the population, these are the clinic-based, and these are the intervention-based studies. Where you can see in the first four bars, which is population-based in the enhanced from in the UK, USA from 1988 to 2008, the prevalence of resistant hypertension has slowly increased from 9.4 to 14.5. Whereas in the clinic-based cohorts, the prevalence is even higher, with this 40% prevalence in patients recorded in the CKD clinic cohort. Whereas in the clinical trial evidence, there's even prevalences of up to 48.5 in certain cohorts. This again is a pooled prevalence of resistant hypertension from observational studies and RCTs. As you can see, there are multiple values ranging from things up to 25% to even values to lower even than 5%. Similarly, in randomized clinical control trials. So, based on all this, the recent guidelines estimate that the actual prevalence of resistant hypertension is somewhere in between 5% to 10%. Do we have any data from Sri Lanka? So, descriptive cross-sectional study of 277 participants in 2009 from the cardiology clinics at NHSL by Dhawan Kumar and Constantine et al. Had shown that 19.1% of patients had resistant hypertension. They also have found out a significant association between resistant hypertension and old age, longer duration of hypertension, diabetes mellitus, and obesity. There also is conflicting evidence from another study from Vijaykaun et al. They have found out that most patients with uncontrolled hypertension is due to other factors other than true resistant hypertension, where only the prevalence is 2.7%. So which phenotypes out of all the hypertensive patients we see are having higher risk of developing resistant hypertension? Patients who are older in age, patients who are male, patients who are obese, and patients who have a higher baseline blood pressure at diagnosis, and obviously patients who consume excess salt, and patients with CKD and diabetes. So in tackling resistant hypertension, we need to understand the basic pathophysiology of resistant hypertension. However, it's very complex and it interplays between multiple factors. The main postulated hypotheses are three factors which says increased aldosterone levels, increased sympathetic nervous system activation with endothelial dysfunction, and increased arterial stiffness. However, certain genetic polymorphisms have also been identified, but these have not been consistent across patient or population cohorts. So the main two factors are the increased aldosterone level and the increased sympathetic nervous system activation. So as previously also stated in previous YBF lectures, aldosterone excess will cause chronic sodium and water retention. It will cause vascular tubular inflammation and fibrosis. It will cause endothelial dysfunction. It will cause impaired baroreflex response and increased sympathetic outflow, and it will also cause insulin resistance and metabolic syndrome. Thus, all in all, it will develop resistant hypertension and maintain the resistant hypertension itself. So why do we need to tackle resistant hypertension? Because resistant hypertension is a warning that the patient is going to have poor prognosis. So Doherty et al. In a retrospective study of more than 200,000 patients has shown that patients with resistant hypertension have 47% more risk of developing adverse cardiovascular outcomes. Similarly, Sim et al. In a popular study with more than 400,000 patients has shown similar results. So resistant hypertension is also associated with worse outcomes in patients with chronic kidney disease and ischemic heart disease, which are common comorbidities in patients with hypertension. So the next question that we have to ask ourselves when we encounter patient with resistant hypertension is whether this is actually resistant hypertension. Most often time it is not. So when resistant hypertension is attributable to other factors, it is called as pseudo-resistant hypertension. So the main four factors which are attributable to pseudo-resistant hypertension are medication non-adherence, the white coat effect, under-treatment, and inaccurate blood pressure measurement. So under treatment, we have already thought about whether we are using the maximum dose in this patient. So the next thing that you have to do is you have to measure the patient's blood pressure correctly. When you encounter such a patient in the clinic, we may run across main caveats when dealing correctly measuring the patient's blood pressure. So, in the correct technique, we must make sure the patient's bladder is empty and the patient has not undergone any significant exercise such as climbing stairs for at least 30 minutes before taking the blood pressure. And the next problem that we'll face is finding the appropriate cuff size. Where in the clinic, we only have one, most of the time, we only have one blood pressure cuff to fit all the sizes of arm sizes of our patients. So after measuring the blood pressure according to the correct technique, still if the patient has high blood pressure, we have to uh, closely look into whether the patient is non-adherent on treatment. So when barriers to non-adherence can be multifaceted from health system level to socio-economic status level, there is no gold standard for measuring adherence to therapy. However, simple measures such as patient self-reporting and pill count and prescription refill data can be used, but which may be questionable in a busy clinic setup. And you always have to look out for these confounding factors which may cause increased blood pressure in the patient. Main culprit is alcohol. So even a little amount of alcohol that is deemed safe can increase the patient's blood pressure. Also, if the patient is suffering from any rheumatic disorders, regular use of NSAIDs and regular use of paracetamol is known to cause increased blood pressure requirements. Also, estrogen and progesterone, as in the OCP pill, steroids, antidepressants, and always in young or maybe even old patients, you have to suspect or think about recreational drug abuse. So if we detect that the patient is having poor adherence to therapy, what can we do to improve the adherence? So using agents that are dosed once daily over those that require multiple daily doses have been shown to effectively improve adherence, as well as using fixed drug dose combination agents whenever possible. So these are the licensed fixed drug dose combinations in Sri Lanka. Out of this, what we commonly have in the clinic setup is losartan hydrochlorothiazide. There are no triple pills that are registered for the moment in Sri Lanka. However, in the trial, telmisartan, clothalidone, and amlodipine has been shown as a cost-effective alternative drug for management of mild to moderate hypertension in patients. And using low-cost generic antihypertensives with effective communication and minimizing the number of trips that the patient has to make to the pharmacy. So after excluding non-adherence, the next thing that you have to do is you have to exclude the white coat effect. So what we can do to exclude the white coat effect is you have to confirm an out-of-office blood pressure measurement. So this is best done by ambulatory blood pressure monitoring. This is one indication for ambulatory blood pressure monitoring. If that is not possible, you have to at least do a home blood pressure measurement to make sure that the patient's blood pressure is elevated out of the office setup. So after excluding all that, then you have to think whether this hypertension is caused by a secondary cause of hypertension. So these are the common secondary causes of hypertension according to the age groups, out of which there are very four common things. First, you have to see whether the patient has any renal parenchymal disease, whether there is any evidence of renovascular hypertension, whether there is any evidence of primary hyperaldosteronism, as well as whether there is any obstructive sleep apnea, which is not classified as a cause for secondary hypertension here, but however, it is classified in other guidelines. So, how to screen? So, yes, we have to take a thorough history and examination to see whether the patient has any evidence of renovascular hypertension, pheochromocytoma, thyroid disease, Cushing's syndrome, and so on. And fundoscopy examination is important to see whether the patient has developed any target organ damage. As basic tests, what is recommended is the basic metabolic profile, serum electrolytes, and renal function tests. An ARR test can be done to exclude primary hyperaldosteronism with renovascular imaging as a renal artery Doppler as the first line investigations. Also, screening for obstructive sleep apnea using the stop bank questionnaire and the EPSS scale can be done if necessary, referred to polysomnography. And screening for other causes, all the other causes of secondary hypertension can be done if clinically indicated and if the initial screening for all this is negative. So this, I think, is a more practical approach for resource poor settings like Sri Lanka. What else to evaluate when you encounter a patient with resistant hypertension? Of course, you have to evaluate for target organ damage, which is ocular, cardiac, renal, and peripheral artery disease. So a UFR to look for proteinuria, ECG, and maybe an echo along with the ankle brachial pressure index. So now we have excluded all the other causes of pseudo resistance, excluded non-adherence, and we are trying to manage a patient with resistant hypertension. So what comes first, of course, is lifestyle modification. Modest weight loss with low caloric diet and exercise has been shown to reduce blood pressure with significant amounts. So we have to advise on weight loss for the patients. But however, you have to be aware of weight cycling, which is losses and then regaining of weight, which has been adversely shown to affect cardiovascular outcomes. So the weight loss has to be sustained. Exercise then itself, moderate intensity aerobic exercise or endurance aerobic exercises have been shown to reduce blood pressure by significant amounts, whereas isometric or dynamic resistance exercises also have been shown to reduce blood pressure but in a lower value compared to endurance exercises. There are extremely sedentary individuals where these sorts of exercises may not be acceptable, where we can suggest low intensity physical activity 6 minutes hourly over an 8-hour period in extreme sedentary individuals. That also has been shown to reduce blood pressure. Next, what to do? We are habitual salt consumers, so we can recommend patients to for a reduced salt intake. So to less than 5 grams of sodium chloride, that is 2 grams of sodium per day is recommended. However, even lowering the salt further than that has been shown to reduce blood pressure, but there's a concern regarding altered blood pressure control mechanisms and extremely low salt intakes. So where they say postulated there's a U-shaped or J-shaped relationship between cardiovascular outcomes and salt intake. Salt substitutes may be helpful where we replace some of the sodium chloride content in salt with potassium chloride is for a place like Sri Lanka. Again, augmentation of the potassium intake. So substituting your sodium with potassium has been shown to reduce your blood pressure as well as improve your cardiovascular outcomes as in the salt substitution and the stroke study. What about alcohol and smoking? So the risk of hypertension increases in both women even at the level of 1 to 2 drinks per day. So in the even within the safe limit, the risk of hypertension increases. So we have to try to get it down to absolute abstinence. So this has been shown in heavy drinkers where 50% cut down have shown dramatic improvements in blood pressure. What about smoking? Smoking directly causes sympathetic nervous system activation and it hinders the action of drugs like beta blockers. And more fashionable approaches like e-cigarettes and water pipe smoking also have been shown to increase blood pressure. So absolutely no smoking has to be recommended. Among the dietary approaches, the DASH diet, which is high in whole grains, fruits, vegetables, and low-fat dairy products, have been the best intervention to reduce the level of blood pressure in patients. Along with that, the Mediterranean diet also has shown some promise. So after doing lifestyle modifications, how are we going to manage this patient pharmacologically? So first, as we mentioned in the deficiencies, that the preferable combination of antihypertensives in patient with resistant hypertension is calcium channel blocker, RAS blocker, and a diuretic. So if the patient is not on those three drugs, we can substitute whatever the antihypertensive regimen patient is on to those three drugs and see. If blood pressure is not controlled, what to do next? So next is optimization of the diuretic drug that is there in the patient's drug regimen. So if the EGFR is significantly higher, more than 30, we can increase the dose of the existing thiazide diuretic, or we can switch it to a more potent or long-acting diuretic such as indapamide or chlorthalidone, which has a more antihypertensive effect than hydrochlorothiazide. But if the GFR is low, There's a place for loop diuretics in management of blood pressure. That is furosemide, bumetanide, torsemide, where this is more long acting and can be dosed once daily. But even at lower eGFRs of 15-90, thiazides may retain their natriuretic and antihypertensive effects, and they can be added on to your loop diuretic. This was evident for clothalidone in the CLIC trial. So if the optimization of the diuretic doesn't work, what is recommended next is spironolactone. So spironolactone can be safely used if the eGFR is more than 45 and the potassium is less than 4.5. This was shown by the landmark Pathway 2 trial, which was a 4-way crossover study where patients with resistant hypertension were randomized into receiving placebo, spironolactone, doxazosine, or bisoprolol, where out of all those 4 arms, spironolactone showed the best outcome, as well as increasing doses of spironolactone from 25 to 50 provided additional blood pressure lowering, and spironolactone was effective across all renin levels. Even in patients with suppressed renin levels, spironolactone was highly effective. So if spironolactone can be used, what about other mineralocorticoid receptor antagonists or similar therapies? So there's eplerenone, there's lesser anti-angiogenic effects, but their potassium blood pressure control is lower, and it, however, is not licensed for hypertension in many countries. Amiloride has been shown to be as equally effective as spironolactone in the Pathway 2 trial, but higher doses of amiloride rather than the normal available preparations of 5 milligram have to be used, which will increase the pill burden. This newer non-steroidal mineralocorticoid receptor antagonists like finerenone, isarexanone, and ocedurenone are also showing future potential therapies. Actually, this isarexanone has been licensed for treatment of hypertension in Japan, and this ocedurenone is been ongoing for resistant hypertension in CKD. Again, newer drugs like aldosterone synthase inhibitors with baxdrostat and lorundrostat has shown early trial evidence for resistant hypertension, especially. So what next? If spironolactone also doesn't work, next is beta blockers. But the problem with beta blockers is European guidelines in 2023 recommend beta blockers to be used at an earlier stage, even maybe as first-line therapy in hypertension. However, American guidelines don't agree, so they suggest using beta blockers only for specific indications in patients with hypertension or even after trying spironolactone. So the beta-1 selectivity and the additional vasodilating properties of beta blockers may be helpful in controlling hypertension. They are nebivolol, carvedilol, bisoprolol, labetalol may be preferable. However, we have some trial evidence from Sri Lanka where in the appropriate study, patients with resistant hypertension receiving either propranolol or placebo with propranolol 40 milligram TDS dose and significantly reduced blood pressure. This was done at NHSL by Constantine et al. So if still not working for with beta blockers, these are our only options remaining. These are alpha blockers, whereas doxazosine, which is extended release preparation, or prazosine and extended release preparations can be used, and central alpha agonist clonidine, guanfacine also can be used. There's good evidence for clonidine in the REHOT trial, where it was almost as comparable to spironolactone. Direct vasodilators also can be used, however, they cause significant fluid retention and reflex sympathetic activation. There's evidence for this endothelial dysfunction in resistant hypertension. So this dual endothelin antagonist like aprocitentan has been shown to be effective in the physician study for management of resistant hypertension. So all of our drugs we have used and still we can't control the blood pressure. So what to do next? So there's evidence for device therapy as in renal denervation in patients with resistant hypertension. So the efferent sympathetic nerves to the kidneys with the increased sympathetic output, increase the renin release and increase the tubular reabsorption of sodium. Whereas kidney signal into the central sympathetic output, central sympathetic activation and outflow that will cause peripheral vasoconstriction and increase blood pressure. So this dual pathway will cause overactive signaling and that will help to promote to increase the sympathetic activation further and further. This is only recommended in patients with EGFR more than 40 and has to be done in extremely specialized centers by expert hands. So the evidence for renal denervation, the trial and the work on it almost stopped in 2014 in this when the simplicity hypertension free trial where patients were randomized to renal denervation or sham treatment. At 6 months, it failed to show any significant blood pressure reduction. But this was attributed to more proximal energy delivery, incomplete denervation, and higher rates of drug change. When these patients were followed up to 36 months, the patients who received renal denervation had documented significant blood pressure decreases compared to the patients who didn't have this treatment. Similar effects have been found out by the spiral HTN on-med and the radiance HTN trial where renal denervation has been found to be helpful. Also, adding renal denervation to stepped antihypertensive therapy has been shown to be better than stepped antihypertensive therapy alone in controlling resistant hypertension as evidenced by this DINER HTN trial. So there are a whole bunch of investigational therapies also that are being trialed for resistant hypertension because sometimes it's very difficult to control. Things like carotid baroreceptor stimulation, central arteriovenous anastomosis, and cardiac neuromodulation therapy using pacemakers also have been tried but have not still been approved for treatment of resistant hypertension. However, these long-acting interfering RNAs, like the things we use in the newer things coming up in dyslipidemia, the silabesiran has been found to have been found to show some promise in treatment of resistant hypertension. And there's also some research ongoing into more traditional methods where things like meditation, device-guided slow breathing, and isometric hand grip exercise are being undergoing investigation for treatment of resistant hypertension. So it's very important to follow up these patients where we have to try to control the blood pressure at least to more than 140/90, if possible to less than 130/80. And you have to treat the patient's comorbidities. There are one comorbidity that is very important is obstructive sleep apnea, which may be a cause and effect both of hypertension, where prolonged CPAP therapy have been shown to reduce blood pressure. Also, if the patient is obese, there may be a place for pharmacological therapy with GLP-1 agonists and SGLT2 inhibitors, which also have some degree of blood pressure lowering and even procedures like bariatric surgery. Also, heart failure with preserved ejection fraction is very common in patients who are obese and patients who are having hypertension. And the drugs which are licensed, the ARNI, also has been shown to have a significant blood pressure lowering effect in patients with higher heart failure and reduced heart failure with preserved ejection fraction. So these patients with resistant hypertension will need more closer monitoring and frequent follow-up for to see for worsening target organ damage, development of treatment side effects, and poor adherence. And when you are dealing with these patients, you have to be always be aware whether this could be going into refractory hypertension, which is defined as blood pressure that is not controlled with maximal therapy with more than 5 antihypertensives. So this brings me to the end of my talk, where my take-home messages would be resistant hypertension is a rising threat to tackle associated with very worse outcomes. You have to always exclude pseudo-resistance and confirm out-of-office blood pressure measurements before embarking on pathway of resistant hypertension. More emphasis should be put down on lifestyle modification and improving treatment adherence, and close follow-up and up titration of antihypertension therapy without clinical inertia is key. These are my references. Thank you.
We have about 4 minutes for the questions. There's a question. An advanced CKD patient with vascular calcification may mimic uncontrolled hypertension falsely. How do you manage that?
So when advanced calcification is known to cause false blood pressure readings in such patients, however, we have to take it in the context and see whether the blood pressure readings are spuriously elevated. And always, if the patient is already having CKD, it's likely that the patient must have target organ damage also associated with that. So, in such a situation, we'll have to assess the patients to see what the degree of hypertensive end organ damage that has taken place by going for more sophisticated cardiac imaging modalities and confirm that the patient's blood pressure is actually elevated. So, other than the oscillometric or measurements, other measurements for blood pressure are not actually approved or recommended. First, I think we'll have to confirm that the patient's blood pressure has actually caused target damage, and then think about controlling blood pressure, even though we can have spuriously high readings.
One more question. We see meter dopa can lower the blood pressure in the system. Is it recommended or are there any concerns?
Methadopa is a centrally acting drug, so that can be done as the 1, 2, 3, 4, fifth line of action after spironolactone and beta blockers according to the current guidelines. However, the central acting drugs can cause drastic. The patients with resistant hypertension are so much used to a certain blood pressure level, so that drastic reduction in blood pressure may not be tolerable by the patient. And as well as there are other side effects of methyl dopa which are commonly rare side effects, but of course it can be used if the blood pressure is not controlled with spironolactone and beta blockers.
Do you use ADP? You will see that you are using
Of course, yes, the fourth generation calcium channel blocker has been shown to be sometimes more effective than the regular calcium channel blockers. But what we see in practice mostly is being used mostly in patients with CKD rather than patients with normal hypertension. Of course, I think we can embark on using it more, but problem is the availability.
All the calcium channel blockers
I didn't know.
Yes, answer. In between people thinking so that maybe partner to this. Thanks for the presentation. This one question, you talk about two cutoffs, 140/90 as the sort of universal cutoff, there is a bigger one, and then 130/80 as the right cutoff. So in between these two cutoffs, have they done studies to see that the patients have had target organ damage, the incidence of target organ damage between the two cutoffs, 130/80 and 140/90. So then in that we came across while you were researching not really, sir. I was so there may be something more to find out there is, and there is target organ damage. I mean, significant target of damage is two cutoffs, so shortly we should I mean recommend you to a cutoff. No data on that.
I did not specifically go into that, sir.
Thank you, Senator. And the Ceylon College of Physicians is thankful to Dr. Senator Sohail Belgam for his well thought out, well delivered